Mark McClellan. I'd like to welcome you all to today's special Accountable Care Learning Collaborative webinar on the recent CMS proposal on expanding bundled payments in the Medicare program. We have a lot to cover in just a half hour, so I'm going to get right into it. On the next slide, just a few housekeeping items. We want to be sure that we're minimizing feedback, so your line should be in mute now, but please do keep it in mute until we get a chance for questions. If you do have a question, you can submit them using the GoToWebinar question box. I will be keeping an eye on those, and we'll incorporate them into the questions in the latter part of this very fast-moving webinar. So please keep those in mind, and please use the GoToMeeting icon to submit those at any time in the call. And I'd also like to begin by introducing our special guest. We're very pleased to have Valinda Rutledge with us today. Valinda is an old friend and colleague of mine, and is currently the Vice President for Public Payor Health Strategy in the Care Coordination Institute at the Greenville Health System. It's a major health system, and there she has some major responsibilities for supporting the implementation of essentially all the major opportunities related to government initiatives like bundled payments and Medicare Advantage, Medicaid pilots, dual eligible primary care, and ACO programs. And Greenville has been doing a lot in this area, so we're great to have her with us from that perspective. But prior to that, Valinda served as a member of the leadership team at the Center for Medicare and Medicaid Innovation, where she helped build the Innovation Center from its initial startup phases. She helped manage the conception, design, and launch of several of the center's major models, including the development and rollout of the Bundled Payment for Care Improvement Initiative, which was a forerunner of this program. And she's been involved in a range of other activities related to care transformation. It's reflected in a long time leadership in healthcare. She's received the Becker's Healthcare Leadership Award and a number of other distinctions reflecting this tremendous background. So, great person to have with us on discussing these issues. Just first briefly, as I see on the slide, just a little bit of orientation to the proposals. This is an expansion of the Comprehensive Care for Joint Replacement model, which CMS announced last year, really reflecting a strong effort by CMS to expand the use of bundled payments and also mandatory payment shifts that move away from fee-for-service, very much in keeping with the Secretary's overall aggressive goals related to payment reform, and I think a clear pattern at CMS of trying to do as much as possible in the time remaining in this administration to advance the ball on payment reform models. So this takes the same kind of hospital-based episode approach, but extends it out. Some of these are to diagnoses, so instead of just having a joint replacement model, there's now a complementary model that includes hip and femur fractures, again triggered by the hospital admission, and some new payment models for cardiac care related to heart attacks, and also a new incentive payment mechanism for cardiac rehabilitation. Another very important clarification in this model, given some of the comments that CMS had received on its initial proposal about implementing MACRA, the physician payment reform legislation, related to some criticisms that there were not that many opportunities available for specialist physicians. They couldn't qualify for some of the primary care tracks that were enabled getting into so-called advanced alternative payment model mechanisms. They might not necessarily be part of a comprehensive ACO that was taking downside risk, which is another main mechanism in the proposed MACRA rule for qualifying for the advanced alternative payment model and bonus that goes along with it. So in this rule, CMS has clarified that physicians who have a significant amount of their payment, their Medicare revenues, through these bundled payment models could similarly qualify for that advanced payment bonus. So that would apply more to the specialists and the surgeons and associated specialists who participate in these models. Going on to the cardiac bundled payment model in a little bit more detail. This is intended to be tested for 5 years, tested at a large scale, hospitals in 98 metropolitan areas, which have not yet been named and will be selected at random. That's different from the way the CGR bundle was set up. And there are several types of bundles. One relates to heart attack, the other relates to bypass surgery. Keep in mind that in the heart attack bundle there will be sort of different levels of payment related to whether or not cardiac procedures like catheterization and angioplasty are performed. And then there's a separate bundled payment with obviously a higher benchmark payment level for bypass surgery. This is similar in design to the BPCI. Rural MSAs are not included. Rural hospitals have a lower risk of loss. Again, the payment episodes are triggered by the hospital admission, so they'll work off the same kind of DRG payment systems that CMS has already widely implemented and that hospitals are already extensively experienced with. And the hospitals, are, as we'll talk about more in a moment, bear the residual financial risk and quality-related performance risk in these hospital-based bundled payments. On to the next slide describes the timeline for implementation and the benchmarks that would be associated with it. Basically, the early years of the program start off with benchmarks for episode spending based on hospital level data, based on the experience of patients historically at the hospitals, 2/3 hospital-based, 1/3 regionally based, and then transitioning by year 4 to being completely based on regional data. This is a transition that some early participants in ACO and other bundled payment programs have asked for. They point out that being held accountable to their historic baselines leaves little incentive for improving on those baselines if that's just going to be cut down later. CMS has been reluctant to implement models that are based on regional benchmarks on a voluntary basis for concerns from the actuaries that voluntary participants will be the ones who just look at the numbers and see that they might do better. By moving to a mandatory model like this one, CMS can more clearly show that it's committed to rewarding the providers that actually lead to that have relatively better results. The target, this benchmark target would be based on a discount relative to historical spending at the hospital level or in the region, but the discount varies based on quality of care. So an opportunity for a 1.5% payment in differential, higher payment by meeting the quality measures associated with these episodes. And that means all hospitals are expected to help lead the way to lowering costs in the implementation of the episodes, but again, an opportunity for sharing in the savings for those particularly that perform well. The next slide shows the extent of the hospital risk and gain opportunities. Upsides initially up to 5%. Again, you don't get the full savings unless you're meeting those quality benchmarks or quality gates. And over time, the up and downside risk increase out to 20% by year 4. Next slide shows the performance measures that CMS has proposed to be associated with the implementation of these measures. Many of these are measures that are already in use and have been NQF endorsed. And that are based off readily available data sources. So for the heart attack or acute myocardial infarction, AMI model, it's 30-day all-cause mortality. This is not hospital mortality, but again, taking more of a population-based focus. It's based on excess days, hospital days associated with AMI, and a voluntary hybrid AMI mortality measure that's a bit more complex to submit, but that that potentially is a better, more sophisticated measure of the mortality risk. And then in terms of capturing patient experience, HCAP survey measure would be included as well. These same kinds of mortality, all-cause mortality-related measures and HCAP survey measures would be used in the bypass surgery model as well. So moving on in our short time to the expansion of the joint replacement models. This is moving from, again, a procedure-based model to a condition. This would include, in particular, treatment for hip and femur fracture, so it goes beyond just joint replacement, and is, I think, an effort by CMS to try to make these bundles more diagnosis-oriented. I'll come back to that. This expansion will take place in the same 67 regions, use the same quality measures as the existing CJR approach. It has a similar structure in terms of benchmark targets, a transition to regional, and opportunities for cardiac for hospitals to share in the gains. And just very briefly, as an add-on, CMS is testing the impact of providing additional payments for use of cardiac rehab, intensive rehab services following discharge. Remember that this is going to be part of the total payment for the total spending that counts against the benchmark in the bundle payments that I was just describing. But it's a reflection too, I think, of the fact that as CMS moves more towards models where there is some financial downside risk for the providers, they're also willing to provide, to give more flexibility in covering services that could actually help improve outcomes, but that under more limited fee-for-service models typically aren't included. Now, this is an incentive payment that will potentially be more widely available, but I'd see it in the context of this overall shift that's taking place towards more financial risk in the bundled episode payment models. As I mentioned earlier, the proposed rule also provides a pathway for physicians who are participating in the specialized area of care to get additional payments under the advanced alternative payment model. The proposed rule will also create a track in each model to qualify for these advanced APMs. So that's a benefit to physicians who are working in the hospitals that are participating in these programs in terms of a payment bonus and maybe more financial incentives to align with the hospital efforts around these models. And again, this is based on CMS's interpretation that physicians who are working with hospitals would meet the criteria in the law, in the MACRA law, for bearing more than nominal financial risk. Now, the risk is borne in the financial model for the hospitals, not directly by the physicians, but because they're participating in that overall model, CMS is going to count it. So that's a very brief overview of the rule. I'm sorry, I'm a couple of slides ahead now. So we've talked a little bit about, on the next slide, the additional changes in the proposed rule, and we'll make these slides available afterwards. And now on to some concerns that have been raised about the rule already. One is that this is still a hospital-based program. Just as there were criticisms of the joint replacement bundle for focusing primarily, if not on some critics' views entirely, on care from the time that the patient hits the hospital to undergo the procedure, the critical view is that the payment reform should really be about support and financial alignment over the whole course of care. So potential steps to prevent and make sure that to prevent the joint replacement, or make sure the patient who was going on to that procedure had been through a shared decision-making process, and it really was the right course of care. I might say, well, these diagnosis-based conditions are a bit different, but some of the same concerns have been raised there, that a lot of the opportunities for improving outcomes and reducing costs related to heart attacks or hip fractures come before the patient gets to the hospital. With that in mind, there have been some criticisms about how well these models fit with other payment reforms, other advanced payment models that CMS is trying to implement, particularly around ACOs. Now, for those of you who work with hospital-based ACOs, this is potentially a reinforcing reform. It provides more opportunities to shift payments and to coordinate care within this overall hospital accountability. But a majority of the ACOs today are actually not led by hospitals, but are led by physician groups of one type or another, often not directly affiliated with hospitals. And some of those physician-led ACOs have had some of the most notable early successes in the Medicare Shared Savings Program, with primary care groups really undertaking significant efforts to use hospital care more effectively to prevent not only readmissions but admissions in the first place, and then sharing in those savings. And those groups in particular are very concerned that carving out essentially the hospital payment bundles will reduce their opportunities to gain in the savings from preventing complications from and preventing readmissions in these major areas of hospital episode payment. I would look for some changes coming in regulation to try to get those payment models aligned better. For example, in the proposed rule, the ACOs that are in Track 2 or 3 or the Next Gen program, those that have significant downside risk, are accepted from the bundle payment rule. So those ACOs still get the opportunity for savings and accountability for their patients who are admitted to hospitals in this program under the bundled payment initiatives. That savings doesn't go to the hospitals. But there's still a concern around the physician group-led efforts, which typically are in shared savings plans. So more to come on that. And also concerns about whether and how well these reforms align with payment reforms taking place in Medicare Advantage plans, other commercial plans that in many cases are taking more of a kind of a longitudinal diagnosis-based approach going back before hospitalizations to create more financial alignment. Also been some concerns about quality measures. There is one patient-reported functional outcome measure in this program, and it's a voluntary one in the joint replacement and now by extension the hip fracture episode program. I think there will be a push at CMS and among many leading organizations to try to expand the use of those more patient-centered models, measures, but they do require additional data from patients. And also some concerns that maybe beneficiaries should be able to share in some of these savings too. So, so just some final thoughts on the next page, and while you're reading through those, I'd like to turn to Valinda with an initial question for her. First of all, Valinda, I'd like to hear your impression about what this means for Greenville. Is this something that fits with your overall strategy? And in the context of answering that question, is there if there's anything that you'd like to clarify or add to my overview, please go ahead.
Yeah, so one thing I would clarify is in terms of the overlap, they have said that the beneficiaries, if you are in just the Next Gen or the end-stage renal disease ACO, if you're a part of those programs, then the beneficiaries are not attributed to the bundle payment, the mandatory bundle payment. Right. But at this point, currently, Mark, they're saying track MSSP track 1, 2, and 3 would still have some overlap. Now, CMS has asked for comments, and personally, I think it's unfair if you're taking downside risk in track 2 and 3 that you wouldn't be included in the next gen and the end-stage renal disease. So that's a point of clarification. Right. I highly recommend all of us write that in as a comment. In terms of what we're doing here at GHS, first of all, we have a very large ACO, 56,000 beneficiaries in our MSSP Track 1, but we're also involved in BPCI and OCM. We're not involved. We were not one of the ones that were selected with CJR. But as I have read this proposed rule, I'm beginning for us to recommend some changes that we make, and also looking at it in the context of MACRA. I think anything that you do surrounding this mandatory program, you need to look at it in the context of MACRA, and I think that's where CMS is going as they roll out more of these programs. A lot of this proposed rule, they actually commented surrounding MACRA, surrounding this rule. So I'm recommending a couple of things. Number one is that we begin to take a look at a template for gain sharing with the hospital. Right now, with the mandatory bundle, you are able to gain share. The ACO is able to be a gain sharer with the hospital that is the episode initiator. So I think as an ACO, you probably need to have a conversation with your hospitals in terms of what that template would look like. That would then allow you to begin to align your ACO and your bundle payment initiatives. I think to remember that this bundle payment is about a condition, and the condition is coronary artery disease. AMI and CABG is just a result of that condition. So if you see the condition being managed at the ACO level and then the AMI and the CABG is managed at the bundle level, you can actually start developing an infrastructure that instead of having sort of angst between the two, you begin to align the structures that would help align the initiatives to achieve the triple aim. The second thing is in terms of MACRA and how it relates to specialists. I think that it is very difficult for any ACO to have specialists on their participant list, and for that ACO to meet that 25% threshold to be able to qualify, as advanced APM, even if you're in an advanced APM track like track 2 or 3 or next gen. And so I'm recommending that we explore actually getting our specialists out of the ACO and potentially move them into what's called the other entity category in an ACO, and actually move them into a different 10 because we have a large academic medical group, but we also have a large number of independent practices in our ACO. But for the large group to actually subdivide it into a 10 that has primary care that would be on the participant list, and then specialists that would be outside, that then would allow those specialists to actually, through not only this mandatory bundle, but also with the new voluntary BPCI, people are calling it 2.0 BPCI, that would qualify for the advanced APM, that would allow those physicians an opportunity to qualify and get their 25% threshold to go into advanced APM and get that 5% bonus.
Thanks, Valinda, for both clarifying that point about how the programs overlap and what sounds like a more viable workaround, at least based on the current proposal for specialists. If you take those steps, does this program work from do you think the program will work from the standpoint of your ACO? You had emphasized earlier that you're really trying to manage the whole condition, coronary artery disease, degenerative joint disease, frailty and avoiding hip fracture risk, as well as effective hip fracture management. Does the combination of ACO plus this approach to handling specialists get you there?
Yes, I do believe that. And I think that you have to, Mark, pull back and sort of say, okay, we're managing the population as a whole, and we're managing the coronary artery disease as a whole in our ACO. However, we have these mandatory bundles that are actually our specialists could be very much aligned with, and actually they have a higher degree of interest in participating in that versus in the ACO. A lot of times, as you know, specialists say the 34 now to be 31 core quality measures for the ACO doesn't have anything to do with many of the specialists. They can't really, are not really feel that it's aligned with them. So you can really get them involved in care redesign that are specific to their specialty. The other thing is you could actually start a infrastructure, think through the infrastructure that you can set up with the hospital being the episode initiator, and then you have the ACO being a gain sharer, you have the physicians, the specialists being another gain sharer, and you could also have your transfer hospitals, the hospitals that you get patients from and send them to, particularly if you're a large academic medical center. And so you could actually think through an infrastructure in which it begins to align all aspects of the ACO, the specialist, the hospital, and the transfer hospitals within this infrastructure through a gain-sharing mechanism that will be found in this mandatory bundle. So I would suggest people think of it in a much broader context than how do I manage this mandatory bundle.
Yeah, that keeps the focus on the overall population strategy, but dealing with some of the complexities of these various Medicare payment systems. And I just want to push on one more point that I think you made, which is that this is not just about the new bundled episode payments, but also about relying on programs like, what do you call it, BPCI 2.0?
Yes, 2.0, yes.
And yeah, please go ahead. I want to hear about how that helps you bring in a broader range of specialty care.
Yeah, so I think that we're going to end up with mandatory and voluntary bundle programs. So we have CJR, now we're going to have this one from cardiac, okay? And I'm not sure that CMS hasn't given me any more evidence in terms of, or clues that they're going to have any more mandatory bundles. They could, but they certainly haven't indicated that yet. However, they have indicated that they will be revising BPCI, and that will come online 2018, which means that they will have to launch it sometime next year. That one will meet the qualifications of the Advanced APM, and that's why they have to revise it to make sure that they meet those. So I think that when you're setting up your infrastructure to align with your hospitals, your specialists, your ACO, and your transfer hospitals that may or may not be in your ACO, then you've got to think of it in a context of you're going to have mandatory bundles and you're going to have voluntary bundles, and how do you put a structure together that would allow you to achieve those triple aim goals.
Yeah, great. Well, we have gone through a number of questions. We are about out of time now. I do want to emphasize, as Valinda said, that while there are a number of different programs out there, and there are going to be more coming from CMS, this approach of keeping an eye on the overall strategy of comprehensive patient management and finding ways within these various programs to make that work does seem like a very promising path forward. And Valinda, we're glad to have you here with us to share that approach today. Obviously, this is a set of topics we'll be coming back to in future ACLC webinars and other activities, so please stay tuned. We'll continue to try to help you keep up not only with the proposals, but as Valinda was just describing, some effective ways to try to make them work together as effectively as possible. So thank you all for joining us today, and we look forward to our next opportunity to work with you in the Accountable Care Learning Collaborative.